Hi, I am Dr. Luis Santiago Ortiz, an internal medicine resident at Christus Health Texas A&M College of Medicine. I'd like to share a case that reminded our team just how deserving syphilis is of its reputation as the great imitator. Our patient was a 57-year-old man who presented with 2 to 3 weeks of progressively worsening blurry vision in both eyes. By the time we saw him, he already had a working diagnosis of optic neuritis and had received high-dose IV steroids. On paper, that seemed reasonable. There was just one problem. His vision was getting worse. And that's where this case really begins. His imaging wasn't giving us much to work with. MRI of the brain and orbits didn't show anything that really explained what we were seeing. His MRA was normal. Meanwhile, his vision continued to decline. Importantly, he did not have eye pain, photophobia, diplopia, focal neurological symptoms, or fever. He also did not report high-risk behaviors that would immediately raise suspicion for syphilis. So syphilis was not exactly at the top of the differential. At some point, you have to stop asking, what else should we do for optic neuritis, and start asking a much more important question. What if this is an optic neuritis? So we changed course and looked more seriously for an infection cause. A lumbar puncture showed a normal opening pressure of 15 centimeters of water, mildly elevated protein, and a lymphocytic predominance. And that's where we found it. His RPR came back at 1 to 128, TPPA was reactive, and CSF BDRL was positive. And well, there he was. This was not simply optic neuritis. This was neurosyphilis with ocular involvement. The great imitator had done exactly what it does best. And this is particularly important because ocular syphilis is vision threatening and can lead to permanent visual impairment if not recognized and treated promptly. What made this case even more challenging was the clinical presentation didn't strongly point us towards syphilis. His syphilis testing was ultimately diagnostic, while alternative infections and autoimmune etiologies were negative as illustrated on the poster. And this isn't something that most of us are going to see every day. A CDC investigation across 8 U.S. jurisdictions found ocular manifestations in only about 0.6% of reported syphilis cases. So this one is pretty good at hiding in plain sight. Now, at this point, we finally knew what we were treating, and thankfully, neurosyphilis has a very well-established preferred treatment, IV penicillin G. Perfect, except our patient was allergic to penicillin. So after spending all that time figuring out exactly what he needed, we had arrived at the unfortunate conclusion that he needed the one drug we couldn't simply give him. And unfortunately for us, Treponema pallidum was not particularly interested in our medication allergy dilemma. Nonetheless, rather than moving away from first-line therapy, the patient underwent penicillin desensitization under close monitoring in the ICU. He tolerated the desensitization successfully and was then able to receive IV penicillin G and ultimately completed the full 14-day treatment course without complication. And I think that part of the case is just as important as making the diagnosis. A documented penicillin allergy didn't mean we had to abandon the treatment he actually needed. With the right multidisciplinary team and appropriate monitoring, we were able to create a safe path back to guideline-directed therapy. There are a few things I'll remember from this case. First, ocular syphilis deserves a place in the differential when unexplained, vision-threatening symptoms are behaving the way we expect, even when the patient doesn't have the classic symptoms, risk factors, or history that immediately point towards syphilis. Second, infection needs to be considered before we become too comfortable with steroids. In this case, the lack of improvement after corticosteroid treatment was an important clue that something didn't fit. And finally, a penicillin allergy doesn't necessarily mean no penicillin. When first-line therapy really matters, desensitization may give us a way to safely provide it. But the biggest lesson for me from this case is actually pretty simple. When the clinical course stopped fitting the diagnosis, believe the clinical course. Our patient worsening vision was telling us that we were missing something. We just had to listen. Syphilis has been called a great imitator for generations. Apparently, it still deserves that title. Thank you.